Nick Rolnick, welcome to Thyroid Strong podcast. Excited to have you here as a fellow colleague and someone who loves to throw heavy weights around and does a deep dive into the research as well as being published yourself. I'm so excited to have you here. So welcome. So we're going to talk about blood flow restriction. For people who are like, what is blood flow restriction? Can you explain it in a very, very simple way?
Yeah, I think BFR or blood flow restriction kind of has a really scary name because every time I talk about this in front of a variety of different people, clinicians and just the everyday Jane and Joe, they're always like, well, wait a second, why blood flow restriction? Don't our bodies need blood and our bodies and our muscles need oxygen? And of course they do. I mean, we need oxygen, but it's interesting because what we're learning in BFR is one of these modalities that is changing how we view some of the physiology and the ways in which we can adapt to exercise. And how we do that, BFR, it applies like a cuff. You can think about it like getting your blood pressure taken. And when you do that, you have this pressure that builds in the arm, in the upper arm, and then it gets to a really tight pressure and then it just releases. Well, with BFR, we're just keeping a little bit of that pressure on and we're asking you to exercise. And as a result of the temporary restriction or the pressure that's applied to that limb, we're now able to stay a high intensity training environment within the muscle in the most simplistic of senses. So that opens up a lot of opportunities for individuals that can't really exercise with heavy weights for one way or another because the muscle doesn't know any different. It's just reacting to the local environment that it's found itself in. And I hate to use the word biohacking because a biohack is things to me that make it easier to do things. BFR is not comfortable.
No.
But it's doing something, right?
Right.
And so, yeah, that's basically BFR in a nutshell.
So for a visual, think of like two blood pressure cuffs. Let's say they're on your legs and they're like as high up in the groin as you could possibly get them. Is that accurate?
Mm-hmm.
And there is occlusion. It's like as if you pumped up the blood pressure cuff, not so that there's no blood going through, but that there's more occlusion. And then you do a workout. But it's not like you're doing like body weight deadlifts, right? You are doing less.
Yeah, I mean, because we can stimulate this high intensity training environment within the muscle, we can use anywhere from no weight to up to 30 to 40% of your one repetition maximum, which would qualify as a light to very light weight. And as I mentioned before, the temporary restriction that is produced from the cuff being inflated signals to the muscle that, hey, I need to work harder than I normally would be working. And up to the point of sometimes exceeding what the results would be with high intensity strength training. And that's basically the gist of it. And if you're not uncomfortable doing BFR, though, you're probably not doing anything. It operates at the molecular level and the nitty-gritty details, operates very similar to how you would put on muscle mass and to a lesser degree strength from lifting without BFR at a variety of different weights, 20, 30, 50, 80% of your one repetition maximum. So it's firmly entrenched in exercise physiology as to what we're trying to do here. It's just a scary, scary name.
It's just a scary name, but I think the thing that people don't know is it's a very, I'm going to say, efficient and effective way to put on muscle without necessarily lifting super heavy for a certain rep scheme. And you can put on that muscle after having surgery just by putting this like what looks like a blood pressure cuff on, because it's creating this like hormonal cascade, right?
Yeah, I mean, me personally, I dislike the narrative of hormonal cascade because if we look at the literature in resistance exercise, acute changes in hormones don't necessarily correlate to long-term gains in muscle growth. And that's really why I use BFR for the fitness setting, certainly, but also in rehabilitation, is that we want to keep on muscle when we're injured, and we want to put on muscle when we're in that not acute stage and we're kind of like subacute, where we maybe have like an injury 6-7 weeks ago. We're not necessarily ready to lift heavy weights, but we want to bridge the gap. And you mentioned before, it is efficient because what we're doing is, if you do the same amount of repetitions with BFR and without BFR over a training period, we already know almost definitively that you're going to get better gains in muscle mass, better gains in muscle strength, potentially improvements in your cardiovascular capacity, because we're restricting the temporary oxygen delivery to the limb. And thus we're creating some changes that are happening at the vascular portion of our muscles. And as a result of that, it's going to outperform that same exercise without BFR. Right. And research is pretty much conclusive that we will get the same benefits in terms of muscle mass as we will lifting heavy weights. Muscle strength, a little bit of a different story, because there are nuances associated with how strength is measured. But in general, for the everyday Joe and Jane, I say that muscle strength is probably going to be very similar to heavy load strength training. But if you have the opportunity to do heavy load strength training, I think that's still the gold standard. It's just some individuals, for one reason or another, are going to be unable to lift heavy.
Yeah. And how would you describe the feeling? Like if someone's never experienced BFR, because it is uncomfortable for someone who,
listen,
like, how would you describe it?
Okay, here's how I describe it to people. So you're doing a hard set of exercise, and that last 2 or 3 reps where you're feeling that sensation, that uncomfortable sensation inside of your muscle that's telling you, whoa, you have to stop. And you have to now really turn on the gas pedal to overpower that, to get another couple of repetitions in before you're really like, oh man, I got to stop. Well, BFR, that feeling when you're doing BFR toward the end of the first set, and certainly in the second, third, and fourth set, if you do it in the traditional recommended repetition range of 30 repetitions in the first set, followed by 3 sets of 15 with 30 seconds of rest in between, that's a lot of volume in the first place. I don't actually think we need that much volume. And we have an upcoming paper that kind of challenges some of the amount of volume that's needed, which may in a certain way reduce the amount of discomfort that's experienced during exercise. But when I initially explained it to patients and clients, I'm like, all right, that last 2 or 3 reps where you're like, I really want to quit, I really got to stop. Imagine that for 4 or 5 minutes. That's kind of where it's at. But I also say this, when we're lifting with light to moderate weight, it's not going to be heavy enough where we're going to be able to stimulate the muscle fiber to grow immediately, right? It's not going to happen. So what has to happen then? Well, if we're on the lower end of the loading continuum, less than 60% is typically moderate to light to very lightweight.
Of your one rep max.
Of your one repetition maximum. All right. So if you're lifting 100 pounds max for 1 rep, you're working at anywhere from between 20 and 50 to 60 pounds, right? That would be moderate weight to lightweight. You can easily do 10 repetitions at that weight very easily and not get tired, right? And when you're not tired using light to moderate weight, well, then you're not really going to be stimulating any sort of adaptation because the load is too light.
Right.
It's a different story when we're lifting heavy. But when we're lifting light, we actually need to create some sort of fatigue, which artificially slows down how quickly the muscle fiber can contract. And that process allows the muscle fiber to experience the environment that is needed in order to promote growth. That is critical. Fatigue is not something that we want to chase with higher intensity exercise because it actually will down regulate our recruitment. But at light loads that we would use with BFR, we need to get into that level of fatigue, because that fatigue, which is evidenced by the metabolic stress, as we reduce the blood flow to the exercising limb, we now are preventing the blood flow returning from the limb. And that causes a pooling effect. And because we're not able to get as much oxygen to the limb and offload those metabolites that are produced normally during exercise, we now get this acceleration of that metabolite accumulation in the limb that causes the burning, that causes the muscle fatigue, that allows us to then put the fiber in an environment for growth. So if you're not burning, you ain't doing anything with light loads. And that is
How about
why
with heavy loads?
With heavy loads, it's not as much of a barometer for me, because when you're lifting pretty heavy, the weight is moving slow to allow that environment for the muscle fiber to stimulate that muscle mass and muscle strength that we're looking for. So metabolite accumulation is not necessarily going to be as good of an indicator, or that burning feeling when you're lifting heavy, because again, you're immediately put into the environment that, hey, you're not gonna be able to move that. If you're a 100-pound bench press or 100-pound squat, you ain't going to be able to move 80 pounds as fast as you're going to be able to move 40 pounds. And as a result of that discrepancy, the muscle fiber is immediately put into that environment where it's like, hey, I need to adapt or die, basically. And of course, the body's going to go towards adaptation. And that adaptation, you're still going to get that perceptual feeling of, I'm working really, 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 really hard. And that could be analogous to the how much benefit you're really getting with an exercise, because if you're working really hard and the muscle contraction speed is very slow, like at the end of a very hard set, whatever exercise you're doing, well, then you're putting that muscle fiber or those muscle fibers in an environment to stimulate those positive benefits that you're looking for, which for my clientele is muscle mass. And I think muscle mass, you are very much aware of the importance of muscle mass. And what's interesting to me, and this is on like Gabrielle Lyon's podcast I was listening to last week, was that they were having difficulties creating this correlational relationship, dare I say even potentially causal, between these negative outcomes and muscle mass. Negative outcomes meaning disease, meaning everything you would think of in terms of the aging process. And it turns out that the way that they were actually measuring lean body mass, which includes muscle tissue, but lean body mass also includes the visceral organs, anything that's non-fat. And they were missing that relationship. And so there's dozens, I'm not really familiar with that body of research, so I can't speak with a lot of certainty, but there, from what I heard from one of the prominent researchers in the field, is that there are so many papers that are misrepresenting the importance of muscle mass, because the way that they're calculating that through DEXA is not really specific enough for muscle. It's just everything. And muscle is just a portion of that. That reiterates, and that's really a paradigm shifting conclusion, because all I see, and in terms of my area of BFR and exercise physiology and the importance of muscle, should dictate better improvement in quality of life, less potential chance for chronic disease, living longer, right? But yet we weren't really seeing that in the research, because the research really wasn't as specific to the actual outcome measure that they were looking to create that correlational analysis with. And I thought that was absolutely, that gave me goosebumps, because it really does highlight that more muscle is better for everyone.
Is there a better measure than a DEXA out there?
Yeah, I mean, I think that they mentioned MRI, but it's very expensive.
Yeah.
Very, very, very expensive. And I think they're coming out with, so that what they did was the scientist developed, and I can't remember his name. It's a shame that I can't remember his name, but they developed because muscle has a lot of creatine within it, they can give somebody an oral supplement, and they can basically based on the amount of urine, creatinine in the urine, they can now understand how much muscle mass that person has. So now that's way more specific than the other measures, and it's way more available than an MRI.
Right.
And that's something that I'm going to be looking into because I heard about it probably like 2 or 3 days ago when I was listening to the podcast in the gym. And I was like, wow, that's really interesting. And that's a commercially or a potentially commercially available way to create baselines. Like for me as a personal trainer, being able to say, all right, well, if this is something that can be commercially available, all right, let's take this, go to a lab, take this. We have a baseline measure now for where you're at. All right, let's look at 3, 6, and 12 months down the line. And now we can see more so than something like one of those bioelectrical impedance measures, which, yeah, they're good, but they're not as precise as we could be.
Like an in-body is what you're referencing.
Yeah.
Let's go back to the burn. So BFR, important to feel the burn because there's occlusion and because low load stimulus. How important is it to feel the burn? You're saying it's more challenging to feel under heavy load?
Yeah, I mean, I think it's a little bit different because burn for me with low to moderate loads, with or without BFR, right, is a signal to me that the anaerobic or the muscle fibers that are not needing oxygen to be able to generate a muscular contraction, right, they're now being overpowered by the type 2 or the muscle fibers that don't need oxygen. And unfortunately, fortunately, unfortunately, however you want to do it, fortunately, that those muscle fibers are very responsive to grow, right? They're the type 2 muscle fibers are the ones that, hey, visible increases in muscle mass and strength, but they're byproduct of them creating the energy to contract is going to create those metabolites. And those metabolites then signal to the nervous system, to your brain, oh, there is an uncomfortable stimulus here. We need to stop the exercise. And at some point, you're like, no, I don't want to stop the exercise. You keep on going, you keep on going. At some point, the stimulus is too high and you literally cannot continue. And that is really important from a low load perspective, is really trying to get as close to failure as possible. And there's no way that you would be able to get to that degree of level of effort without feeling that burn. So usually, like, I'm much less married to the traditional loading schemes. And I would much rather say, hey, just let's do the exercise until you start to feel a burn. Let's try to get 3 to 5 more reps in after you really start to feel it. And after you accumulate that over 3 to 4 sets, you're definitely going to be putting yourself in a good, positive way to adapt to that stimulus. On the converse, if I'm only lifting 4 to 6 reps, maybe 8 reps, you're not going to, the metabolite induced discomfort is much less. It's more the discomfort mentally of the weight's heavy. I got to really push forward. You're not able to move the weight quick. And yeah, do we get those metabolites after the fact? Yeah, we do, because it's resynthesizing the energy, but we're not occluded. So we don't really feel that burn because the metabolites that are produced are able to exit the venous system and get away from the muscle.
Right.
So I think there's two separate, one is more of a psychological, I'm really going to work hard. The other is a psychological and a physiological, like, oh, like, my gosh, like I got to work hard and I got this massive burn. But that's why it's very difficult to do BFR for a long period of time, because it is so mentally, like, you have to prepare yourself. And so the funny thing is, like, when I go and I teach blood flow restriction, I'm the BFR guy that doesn't use BFR that much, because it's only a select portion of people that if I can't get them to lift heavy, and for that period of time they can't, then I'm going to be using BFR because I already know it's going to outperform. But the cost is, it's uncomfortable. But that should also mentally say, all right, well, if I know I'm uncomfortable, then it must be doing something beneficial, particularly paired with exercise.
Right. Can you speak to why Because I think a lot of people are like, oh, to get hypertrophy, you have to hit, what is it, like 12 reps, 12 to 15 reps. But maybe, and obviously you do way more study of research than I do, but maybe it doesn't have to be that rep scheme to be able to create muscle hypertrophy.
I mean, I think BFR kind of put the nail in the coffin regarding what we call like an effective repetition range for hypertrophy.
Yeah.
Traditionally, the bodybuilders, it's 8 to 12 reps for hypertrophy, 12 plus or 15 plus for endurance, and 1 to 5, 1 to 6 for strength.
Yeah.
And this is where I've been very fortunate to have been mentored by some of the smartest guys in the game, strength game, like Chris Beardsley, Brad Schoenfeld, those type of caliber of people who are literally living and breathing in the research. And with what we're learning about muscle hypertrophy is you really need one thing and one thing only. And it just depends on how you get there is what type of weight you're lifting. One is very quick to get there. The other takes a little bit longer. And that one thing is this, is that weight, when you are doing a concentric or when the muscle is shortening, so you're doing a bicep curl, you're flexing your elbow, right? That has to artificially slow down. And you need to be working very, very, very hard to be able to keep that muscle from stopping. And at a certain speed, right, a certain velocity of contraction, which really in practical sense doesn't matter. It's really just at the last 4 or 5 repetitions before you get to muscular fatigue is when you're creating that type of stimulus. But when you are artificially slowed down because you're fatigued with low loads, for example, or it's a very heavy weight and you're not going to be able to move that weight really quick, such as with heavy loads, then you're going to get at the muscle fiber level, it's not going to be able to shorten as quickly. And that is the stimulus for hypertrophy. Literally, it's involuntary slowing of that muscle fiber with high amounts of effort, like you working really hard to be able to continue. We get that immediately with heavy loads. We get that in a little bit with moderate loads, like 50 to 70%. And then with light loads, we ultimately get there, but we have significant metabolite accumulation, or AKA the burn, because there has to be some sort of fatigue that's generated in order to be able to get us to that physiological stimulus, which is that involuntary slowing of the muscle fiber contraction speed. And then as you get to failure, and you probably know this, the listeners probably know this, regardless of what weight you use, it gets harder and harder and harder to do it the closer you get to failure. And that is the physiologic stimulus that, for me as a physical therapist, as a personal trainer, like I want all of my clients to get to every single set. Because if you're not getting to that point where like just today, I came back and like we're first time doing an exercise, I picked a weight and I was like, all right, do 6 to 8 reps. All right, how many more could you do? Oh, I could do 15. All right, well, then we're going to go up a weight. We're going to go up a weight and we're going to do it again. All right, estimate how many. And then we find within 2 sets, we find a working weight. But that working weight is such that if I'm asking him to do 10 reps, I want him to be able to only do 12 or 13 reps before failure. So there's still like 2 or 3 reps in the tank. And that is kind of the clinical or practical significance of this. It's like, it doesn't need to be that complicated. I think that there's this, and this is fitness, this is rehabilitation. There's this appeal to complexity. Whereas if things are more complex, then they must be better than something that is more simplistic in nature. And I think that there's a lot of, and that's what leads to a lot of confusion in the nutrition field as well, right? To try to keep a hold of nutrition in the literature, I tried it for like a month and I was like, no, forget it, just too much. I was just think you have a model and what fits in the model, what doesn't. And if it doesn't fit in the model, then you have to amend your model to figure out a way to make juice out of the squeeze. But this model of involuntary slowing and how you get to it makes complete sense. I've yet to find any sort of exception to that rule or to that model. And that's what I kind of tell my clients, just work hard, regardless of what weight we end up using. That's literally it.
Right. If you were going to explain it to a client, because some trainers use like rate of perceived exertion, 7 or 8 out of 10. How many more reps do you have in the tank? How would you describe it to someone who's like, okay, have I hit fatigue? So the muscle is slowing under load. Do you use like how many more reps in the tank or like rate of perceived exertion?
Yeah, I mean, I like to use, and it really just depends on, because I'm a physical therapist, so I work with individuals that are injured that have reduced capacity anyways.
Right.
So my thing tends to start out with further in reserve. So for example, like if I tell a person, I was like, listen, I want you to keep on moving or keep on exercising until you feel like you have 3 or 4 more reps until you can't do another one, right? So maybe that first time they're exercising, they got 14 reps. All right, that means that they could probably do 17 or 18 reps. So I know that at that point, I can probably increase the weight as long as their pain is under control, all these other checking for the rehab related things.
Yeah.
And I tend to then say, listen, like when you're a beginner, your perception of how hard you're working is impaired. It's a skill, much like everything else. You're not going to be an expert at being able to determine how far you are from your muscular failure. So usually in the first session or two, I try to be as conservative as possible. And then when I get an idea, and an easy clinical indication is like they're moving and you see kind of like a stagnation. Like when you're doing a bicep curl, it's very smooth, right? That's it. But then you start to get these little juts or on the muscle shortening or juts on the muscle lengthening. I know that they're getting there. And so a lot of my job is really to put my clients in an environment that they can just focus on moving the body from one point to another point, and whether that's with machines, whether that's free weight, depending on the context, but there's going to be a learning curve to the reps in reserve, how hard you're working, because think about it. If you've never exercised before, and now all of a sudden I'm asking you to do 1 set of 10, it's literally your effort would be from resting to whatever you're doing is already infinite because you haven't done anything. So there's, of course, this funneling process where you're going to get to that point. And I don't tend to put my clients in failure for, I mean, if it happens by accident, fine. But certainly my goal is for the first couple of weeks is get them comfortable with the exercise stimulus and trying to figure out where they are. And then I'll standardize it for them at some point after 2 weeks, once they've gotten some of the repeated bout effects. So like you do an exercise once and you do the same exercise at the same intensity the next time and you don't get sore. That's what we call the repeated bout effect. So I want that to be in place before I really start to push clients along, because that's where you can get hurt from a rehab strengthening perspective.
Yeah.
But yeah, it's a learning curve. Long story short.
Yeah. What is the soreness like after using BFR? Is it because a lot of the autoimmune population will get really sore under not a lot of stimulus for like 5 days?
So I can only attest to myself and my clients' soreness. So I've worked with a couple of patients that have degenerative muscle conditions. Their muscle is not healthy. I've worked with individuals with osteoarthritis, rheumatoid arthritis.
The rheumatoid arthritis is an autoimmune condition.
Yeah.
Were they like more sore than maybe your normal client that doesn't?
I mean, I think that controlling the dosage a little bit more. And I'll explain that in a second. There's one more that's coming off the Ehlers-Danlos.
Yeah. Joint.
So I was, yeah. And the thing is this, I think from a soreness perspective, when we're not doing anything and then we do something, we're of course going to experience an increase in soreness. I don't work with a lot of individuals with autoimmune, so I'm only speaking from my experience at the Gen Pop and some of my other rehab specific. But the soreness with BFR, this is an interesting area because they're thinking that because of the low loads, and without getting into like the nitty gritty, that because of the low loads, and we're able to condense the time spent in exercise using low loads, we're not accumulating as much muscle damage. However, there's a caveat to that, and that muscle damage may or may not be related to how sore you get, right? We think that there's some relationship, but a lot of studies show none. And either way, all the soreness tells me is that the body has done something a little bit more than what it was used to, and it needs time to adapt, basically. For whatever the physiological underpinnings of that is, I mean, that's for real physiologists to determine. But from a practical perspective, BFR, when you do strenuous BFR exercise to failure, some studies show that it has significant amounts of muscle damage. Others show little to none. It's a very interesting area of research. In fact, I'm presenting at the National Strength and Conditioning Association's national conference on screening in blood flow restriction training. And me personally, I think that there are a very, very, very few people like with different conditions that are inappropriate for BFR. I really do think that BFR can be used by everyone. I really do. It's what really sold me was in University of Miami at CSM Combined Sections Meeting, which is the largest physical therapist meeting in the United States. They're having individuals in the intensive care unit that are mechanically ventilated. They're having them in bed cycling, doing blood flow restricted exercise. Okay.
These people are awake. They're not like in a coma.
Yeah, they're awake and they're doing unilateral BFR exercise. And these are the sickest of the sick patients. Not only that, there's more research that's coming out that's showing that temporary full restriction. So basically taking your blood pressure and keeping that pressure that's tightest on for 5 minutes on and 3 minutes off actually has cardioprotective effects. So they're doing this before surgery, and they're noting that they're seeing that reduced opioid release, opioid consumption following surgery. They're seeing improvements in function, and that has to do with ischemic protection. This gets back to what I was talking about with the repeated bout effect, and you said the soreness with BFR, is that when we give our body a stimulus and we give it time to adapt, it now becomes stronger in the future, and we're less likely to experience a negative outcome following that. So temporary with blood flow restriction, I tend to not do a full protocol for individuals that I feel would be at risk of experiencing excessive soreness, and do more of the traditional work. So if you're doing 3 sets of 15 normally, just do 3 sets of 15 with BFR. You don't need to do 30 reps followed by 3 sets of 15 like the traditional protocol. And that at least gives you an opportunity to experience the stimulus, but not enough volume where you're going to get extensively sore. But I do want the listeners to appreciate that because the weight is light doesn't necessarily mean that it's not strenuous on the muscle fiber. When you reduce the oxygen delivery to the limb, it serves as a vehicle to accelerate the fatigue because we're trapping metabolites, right? And we're obviously reducing some oxygen delivery, although how much is really debatable and kind of nuanced, believe it or not. But that ischemia can create changes intracellularly that stress the mitochondria, the powerhouse of the cell. And if the mitochondria is not able to scoop up some of these ions, mainly calcium, then it builds up inside the cell, and then it can cause muscle damage and then create that soreness. So that's why we just need to respect that BFR has the potential to induce significant soreness and muscle damage. But with a proper integration program, I really think BFR you can do BFR, treat it like any other traditional strength training approach. What's interesting is I've had clients that I put them in the ground, basically, like doing supersets, drop sets with BFR, nothing, leaving the clinic. Yeah, leaving the clinic, barely walking, coming in the next day, like I feel great, ready to go. Because it's the low loads, you're not creating the mechanical stress on the joints. So it's very easy to recover from a joint perspective because you're not loading him, but you're really stressing the muscle. And then again, just getting together with somebody who's familiar with BFR and can offer some programming guidance is really the key to long-term success with this exercise approach.
Yeah. So a lot of the autoimmune population have a harder time maintaining their muscle mass. Or if it's a thyroid condition, hypothyroidism, much harder to maintain our muscle mass. Same thing through menopause, right? And a lot of women who get diagnosed with an autoimmune condition, specifically Hashimoto's, will get diagnosed either perimenopause or menopause, maybe because there's a change in estrogen. People don't really know why. So like this is a population where I'm like, these people need to do BFR because they struggle with joint pain and muscle aches just from potentially being hypothyroid and not having enough active thyroid hormones circulating in the system, but then they're also fatigued easily. So are there any research papers out there, that population, maybe not necessarily autoimmune, because that's definitely more niche, but like the menopausal population, maintaining muscle mass and BFR?
This is a great segue to kind of circle back to what we talked about with regards to stimulation of muscle mass and the associated benefits of that. If we understand that we're pushing ourselves be like to a level of exertion with the muscle burn that we talk about that can trigger a high intensity exercise environment within the muscle, then we should expect a couple of things. We should expect that regardless of the population, right? For the most part, there are degenerative muscle conditions like polymyositis, dermatomyositis that very difficult to put on muscle, but they do show some preservation of strength, which is another thing. But for the general non-degenerative musculoskeletal conditions, if we stimulate muscle, we should experience an increase in muscle mass and somewhat an increase in muscle strength with that, and then improvement, hopefully, in functional activities of daily living. So getting up out of a chair, walking 6 minutes and recording the distance and things like that. So in regards to any population, this is the narrative that I take. More muscle is always going to be better. And we know that the muscle is going to have these exerkines or myokines, whatever you want to call them, that will, when we contract our muscles, help to regulate the inflammatory process. We know that higher levels of inflammation are going to impair muscle protein synthesis. They're going to impair a lot of the biological processes that help us be ourselves in the most simplistic of terms. With regards to postmenopausal women, there are actually like 5 or 6 studies on BFR. And with that preface, they do exactly what I just said they would do if we are accelerating the load or we're accelerating the fatigue accumulated at light loads, and we're now comparing it to high intensity strength training. So the majority of the research, I think there's at least 5 or 6, with one being just an acute, the rest being training studies, either in water, like water exercise program with BFR compared to a water exercise program without BFR, or a low load strength training to low load strength training with BFR to heavy load strength training at 60 to I think 70% is the highest one that I found. Nonetheless, it shows exactly that. BFR equals high intensity strength training and sometimes outperforms high intensity strength training in functional measures. That could be due to joint issue. Again, it could be you just kind of go down that funnel, and then it outperforms low intensity exercise. There are another paper that I came across that looked at bone marker, looking at molecules associated with positive bone marker formation, showing that BFR actually can induce similar as high intensity strength training. All of these things make complete sense when you start out with the picture of muscle is what we want and what we need, because there's this interrelationship between muscle and bone. And even now we're seeing muscle and tendon and muscle and vasculature. So if we can promote muscle mass in a bodybuilding style, or however you want to do it, it doesn't really matter. Muscle is going to be the best medicine that you can have at your disposal, and it's free. Like, that's the thing that is unbelievable to me, is the more I learn about chronic disease, the more I learn about optimizing human physiology performance, the more I see muscle as this, like, literally this pivotal tissue that can help solve. I mean, again, you look at chronic disease, you look at cancer, all of these things where muscle plays a role because it regulates that inflammatory process. And then you translate that to function and you translate that to quality of life. And it's just like a no-brainer. So where BFR for me fits in is like, if we have people that just can't lift heavy for one reason or another, let's cut the time needed to get a training effect at light loads and kind of bridge them, if possible, to higher intensity strength training when they're able.
Right. When you're referencing bone, is it like BFR could change bone density? Like in the...
So there's been a couple of papers that have looked at bone marker formation, which is not changes in bone, right? These are just basically things that we would look at to expect that there would be a positive benefit. But we do know from the research there's an interrelationship between muscle and bone. The healthier your muscle, the healthier your bone, right? Generally speaking. We have one paper that was published last year out of a group in Houston Methodist, and this was the first evidence that used MRI to track after an ACL reconstruction. They looked at muscle mass, but they added bone as a comparator, and they looked at with and without BFR, and they looked at the distal femur, they looked at the proximal tibia. So these are like the knee, or all around the knee, where the ACL would be plugged in, and around the fibula as well, which is that side weird bone that people have on the side of their knee. And what they found was BFR, compared to the group that didn't use BFR, the group that used BFR showed no bone mineral density loss. Like they actually looked at it, and the paper is open access, so you can go check it out, compared to the non-BFR group. So that was really one of the first pieces of evidence that came out that says, oh, wait, like there is a potential. Now, again, it's one study, right? But if you look at the totality of things, it's like, all right, this is just more and more research is going to come out. It's going to continue to support this. But if you're looking at it from an evidence perspective, yeah, it's one study. It's a randomized controlled trial, but it really is like the first piece of evidence to say, oh, wait, like there is actually not only a muscle sparing effect, but there is a bone sparing effect with the use of BFR. And you can get into the mechanisms and why that's the case, but generally we can track muscle that then pulls on the bone. And then when it pulls on the bone, that creates that mechanotransduction at the bone level. And that signals, oh, I need to adapt and whatnot. Yeah. But yeah, that was super, super cool to start seeing that. What is the missing piece on all of these? Tendon, bone, vascular, it's all muscle.
Yeah.
Like that's the thing that's super, like I'm a bodybuilder, like muscle has always been an aesthetic thing for me. But when I talk about it to my clients, it's really, the aesthetics are actually a bonus. They're like a reward for you basically taking your medicine.
Yeah.
Like it's a reward.
Yeah. If someone wanted to do this from home and they want to start to explore this, is there a favorite cuff that you like?
I think it's always the question that I get asked. I try to stay out of the cuff wars. I mean, my research interests are what separates different cuffs from each other and their potential impact on BFR. I think that if people want to start using BFR, I think it's important to have either technology that you're unable to occlude, meaning that it's physically unable to restrict blood flow to the degree that it's going to cause some sort of occlusions, because God forbid something happens and you have a cuff on and it can't, and you're occluded, and now all of a sudden 5 minutes is safe, but like 25 minutes, like I don't think that would be something that I would really want. Yeah. So there are cuffs that do that really market that they don't occlude, and they're B Strong, B3 bands. Me personally, I think there's other options out there that we know BFR is largely safe. We just need to calibrate it in terms of a pressure. We know that there's a minimum pressure needed to actually accelerate the fatigue process. So if we don't understand what is our limb occlusion pressure, or that blood pressure cuff when it gets really, really, really tight and then it comes off, in essence, it's analogous to our systolic blood pressure at that particular cuff width. If we don't know that value, then how are we going to be able to determine that we're meaningfully accelerating the fatigue process? Now, so like B Strong, B3 bands, fine. They're safer, quote unquote, because of their design. But I don't like them from a research perspective. I think we need to be better and a clinical perspective. I think that if we have the opportunity to use it in clinic, I would probably not choose that. And then we have the single chamber bladder system. So the traditional, what we would call tourniquets. These are when you inflate it, it will apply a relatively circumferential pressure around the limb. Those cuffs, they're now, with the massive amount of interest in blood flow restriction, there are tons of money being poured into the industry that are making BFR training more accessible and less, I don't want to say risky, but less less work on the person that's actually exercising. And for example, that just means that there are technologies out there that can calibrate your limb occlusion pressure itself. So you put the cuff on, you connect it, you press a button, it will pump it up, and then it will give you your limb occlusion pressure values. So the one that I use the most in the clinic that is not purchasable by anybody is the Delphi unit. That is a retrofitted surgical tourniquet device. So unless you're a clinician, you can't buy it. But I tell a lot of people to buy there's a new cuff that came out, Smart Tools. It has a wireless now, completely app integrated. You can buy it, you download the app, you can immediately go, it'll tell your LOP, you can save your exercise. I think it's been I got a set about 2 weeks ago and working through it. And I think that by and large, there are a few hiccups, but with any product launch there is. But I think by and large, it's a really good, solid device, but it's not that cheap relative to the other devices. So you get what you pay for. But
is it adjusting? So you're like set it to a certain occlusion, and then, because I have like an older smart cuff, I think, and like it loses pressure the more you're working out. Does it adjust in the moment?
So
like a Delphi unit?
You're talking about auto regulation, and it doesn't.
Okay.
But it maintains pressure. So like in between every set, it will actually there's definitely something going on. There's a sensor that will make sure that you're exercising at that particular pressure.
Yeah.
There are other cuff companies that are out there like Airband, Saga. These are cheaper. Again, you get what you pay for. I've had trouble with their Bluetooth connectivity. I've had trouble with just their cuff design in general. I was really enthusiastic about that cuff during COVID because it was the first one that was really virtual, but I have not had much success with that brand. And then there are other cuffs that are manual cuffs. And these are things like Fit cuffs and H plus cuffs. They're a little bit less expensive, but you have to pump them up yourself. But they're good quality cuffs. And I was involved in a study that kind of answers this question that you're asking, which is, okay, we need to determine our limb occlusion pressure, right? Well, what if we use a cuff width between 9 and 13 centimeters, which is basically the cuff width of almost every single cuff that's out there. And what we found was whatever your blood pressure is, 1.3 times your blood pressure is actually your limb occlusion pressure. In most cases is your limb occlusion pressure. So you can use that for cuffs in the arm and cuffs in the leg, and then just calculate a percentage of that. We also found that just pumping it up to 100 millimeters of mercury is about 60% of the limb occlusion pressure without having to take into consideration, actually measure. And then brachial systolic blood pressure is about 80% of your limb occlusion pressure. So if you don't have a Doppler, it's not the end of the world. That's why we're trying to create accessible algorithms for you to exercise. But the gold standard really is if you have the opportunity to purchase an automatic device that's been validated, like the smart cuffs have been validated in the research, meaning that they're applying the pressure that they actually are applying, and it is your limb occlusion pressure. Those are really preferred from a safety perspective. But again, I'm just happy that people are getting involved in some sort of BFR exercise I don't make money if you go and buy cuffs
Right.
after this. It's mostly like, I'm very interested in just making sure that BFR continues to grow safely.
Yeah.
And that's where my research interest lies, is the safe growth of BFR, how challenging BFR is, because it's really challenging, and the different devices that are out there, and studying them and figuring out, do some of the features, like you mentioned, autoregulation, where the cuff automatically adjusts. Does that actually matter from a safety and or performance perspective? And we have another paper in review. We published one paper that showed that with the smart cuffs, it actually did make a difference. But then we used the Delphi unit in our second study and showed that it actually didn't. But the Delphi unit actually blunted some of the arterial stiffness, so the sympathetic response at the aortic arch. It actually blunted that relative to non-autoregulated and low intensity exercise without BFR. So we're still kind of just getting our toes wet in this thing. But even now, I don't necessarily think that autoregulation is the be all end all. I just think that it's a nice feature that if you're working with very at-risk people as a physical therapist, chiropractor, athletic trainer, whatever, that it's nice to have. But I don't think that, I think that there are other things that are more important in the BFR application, like adhering to recommended guidelines, right? Making sure you're providing an acclimation period for the exerciser, so you're able to get that repeated bout effect, and then you're able to really push them and not have to worry about any sort of serious adverse events, because you're monitoring them all along the way.
Right. Last question. If I'm a menopausal woman, I'm deconditioned, maybe I walk, what would be like the basic programming? Would it be like BFR twice a week on a treadmill?
I would literally have them. So beautiful that you asked that, because we really didn't talk about cardio. But I would say, what's meaningful for you? What's a meaningful activity for you? If you're walking, you mentioned at the prom, I would say, all right, well, let's now start out with, let's do 2 minutes to 3 minutes on, 1 minute off on the treadmill. Accumulate 15 minutes. Okay. Then now the next bit is like, with aerobic training, it's not as stressful, but you're able to get, especially in deconditioned individuals, older adults, they actually published a meta-analysis on this, and they showed that just walking on the treadmill can improve muscle mass and muscle strength in older adults. And that's not even including any of the cardiovascular benefits that exist, because now you're increasing the intensity of just a regular walk. So I would start out light, and that's a great introduction to BFR, because that's not super strenuous. I rarely have had people in my 7 years using BFR, when I started them off with walking, have come back and be like, wow, I'm really sore.
Right. And you're doing that a couple times a week, or?
Yeah, I would do 3 to 4 times a week. When you have very low intensity type exercise, the more frequent you do that, the better it's going to be. When you start to get to resistance exercise, you don't need to do it as often. Twice a week, maybe 3 times, depending on how much volume you're doing in your session. But again, it's like, the more that you add in terms of load, the less frequent you have to do the exercise. So like with BFR, you could probably get away with doing BFR 4 times a week, especially if you're using 0 to 20% of your 1 rep max, whatever that would be, right? And then as you start to transition to 30 to 40% with BFR, maybe you only need to go 2 to 3 times a week, maybe 2, right? And then you transition to heavy load strength training, and that's twice a week, right? Typically, if you're doing a body part split. So like it follows the same principles as traditional strength training.
And like, you could do BFR, you could put someone on a treadmill, do BFR, and then take the cuffs off and then do a session.
I mean, like with low intensity BFR, the recovery, especially with aerobics, is pretty quick, if not in the same session. But yeah, it really just depends. Like, I would always go with, if I'm coming into the gym and I'm fresh, what is the 2 things that I want to get accomplished in the gym today, and program those first, because you're going to be the most fresh, you're going to have the most energy, and most focus for those. And those are the things that you're going to reap the most benefits out of. So if it's BFR and something else, or if it's 2 other things and then you're finishing up with BFR, right? Like, those are it's just prioritizing what you're going to be doing in your session.
Got it. Nick, super helpful. I feel like everyone should be doing BFR. There's like No reason why not. Where can people find you, and where can people find your education around BFR?
People can find me on Instagram. I should be more active, but the HPM, just short for the Human Performance Mechanic. That's just my clinic and my personal one. And we also have the BFR Pros, which is my education one. And then
Bros, not bros.
it's pros. Yes.
Got it.
The BFR Pros
Bros.
Instagram. And we have a Facebook group, BFR Pros Accelerate Performance and Recovery. It's a public group. You can join, ask questions. Again, got to be more active on that. This is just another impetus for me to do that.
And you have a clinic,
And
like a clinical course.
yeah, and then I have a clinical course that really breaks down BFR, kind of reiterating the same fundamentals that we talked about. That's on www.bfrtraining.com. And shameless plug, I also own bloodflowrestriction.com. We're going to be launching a massive type of website that's all things blood flow restriction, of which at some point a podcast will appear on there.
Awesome. Awesome.
But
Nick,
yeah.
thank you so much. So informative, and so many people don't know about it. And I think there's just so many benefits, especially to the autoimmune population, especially to the menopause population, especially to women who fatigue easily and get joint pain easily. So thank you.